Hi, my name is Brandy. Welcome to another educational series by Mana Health Partners. Today we're talking about advanced care planning. Our objectives are going to be to talk about CMS guidelines for billing and coding for advanced care planning, and then the requirements for coding for advanced care planning with the CPT codes. So for Medicare or CMS.gov, there are certain requirements that need to be not only discussed, but documented when we're doing advanced care planning. So under this billing and coding from CMS.gov, it talks about the text or the article that we're talking about, which discusses billing, coding, and other guidelines. So we'll go through those. This is directly from Medicare. It talks about voluntary. So the discussion that we have is going to be voluntary. It talks about who is going to perform that, Medicare physician or another qualified healthcare professional, which would be a nurse practitioner or a physician's assistant. It talks about either having the discussion with a patient or family members or surrogates. And surrogates are defined as healthcare agents, decision makers, family members, or caregivers. The reason why the patient is not able to be present. So if we've got a healthcare surrogate making those decisions, then we would want to document the reason why the patient couldn't participate. And then lastly, there is no limit on the number of advanced care plannings that can be reported. You can report as many as necessary for the patient. However, when you're doing that documentation for a second or third advanced care planning session, you have to have the reason why you're having this discussion. That change of condition or the change of wishes needs to be documented. So under CMS.gov is where I got this article from. It talks about the billing and coding. And so as we're doing documentation, that must include multiple things. So the content and medical necessity has to be discussed, the nature of the encounter, the content of any advanced care planning that we do, the names that are in the documentation that we spent time with, the time spent in the encounter, and then the start time and end time is best practice. So as a MANA nurse practitioner, all of your initial visits should have advanced care planning in your initial note. If the patient's alert and oriented, and if the patient is a full code. Advanced care planning is not required for patients that are do not resuscitate unless there's a change. They determine they want to go on hospice or palliative, or they want no more medications, any kind of change medically, they can have advanced care planning as well. For all patients who are incapacitated, have a guardian, a low BIMS score, or have someone that you're going to have an outside conversation with, you have up to 30 days from the initial visit to make that call or have that conversation with the healthcare surrogate. So every single patient that is a full code needs to have an advanced care planning discussion. So advanced care planning ensures that equitable care is present for all patients, regardless of their cognition. So if you've got a patient that is or is not alert and oriented, both patients get the same care. So advanced care planning starts with a conversation. So you're going to have the discussion about advanced care planning, and then you're going to come up with a plan together based on what their needs and wishes are and what their values support. And then you're going to document what choices were discussed. With Mana, we use True RCM, and this is the template that pops up. There's a little dash that has advanced care planning. And when you click it, you've got the date section, you've got how many minutes, and then you've got a blank box. Under that blank box, you have two choices. You've got a snippet for a discussion with a patient and a snippet for a discussion with power of attorney or healthcare surrogate. You are not allowed to type your own information into this box. The rationale is that you could see that CMS requires a lot of specific documentation, and that documentation will be covered in one of these two snippets. So you can use either snippet to start your note, whether you're doing it with a power of attorney or a patient. Note that a snippet is a short, pre-written piece of text or code designed to convey specific information, provide a template, or perform a function. So at Mana, every snippet needs to be adjusted, edited, and customized based on the unique context of individual needs of the situation. They should not be used as universal. You should not edit them. And it's not a one size fits all. It's just a template that you start adjusting. Templates have been made to include multiple answers with the intent to delete what is not applicable, and then your statements end up correct. So when we go to the first one, you're going to either do the discussion with the patient or the discussion with the power of attorney. This is what it's going to look like. It's going to be a big template with a lot of snippets attached to it. Each snippet needs to be addressed. You delete what's not applicable, and what is applicable stays. No specific section is going to be deleted. Only the answers to the snippets. So here's one that talks about meeting Medicare or CMS requirements. So you've got your statement, the names of the participants. We just put patient because that's who participated. Does it meet medical necessity? What is the content discussed? What is the forms that were completed? And then what is the time spent? So each section that was required by CMS is documented here. So here's an example of a full code. You've got a voluntary, and CMS says it has to be voluntary. So this blanket statement, this snippet, already meets criteria by saying that we had a voluntary discussion. It also is where you're going to adjust either the patient's name, because this is the one for the patient, or if you're doing power of attorney, then you would adjust the power of attorney's name. The rest of the snippet stays the same. The next one is medical necessity. So recent health status change or advanced care planning wishes that prompted advanced care planning discussion. So that would be for all of us nurse practitioners assuming care of a new patient or an assumption of care as we go into a building for the first time and we meet the patient. We're going to establish care with that patient as a new provider. So we want to make sure that we've got what their wishes are, what their values are, and that we're documenting that. And then what the content is. What are their goals of care? Well, it was a full code patient, so I selected curative and aggressive management, and then I deleted everything that was not applicable to make this sentence or this snippet accurate. The content of any advanced directives. So we're going to discuss healthcare proxy, durable power of attorney, living will, and a pulse. So the question then becomes, do they have any questions about those forms? Do they need any help filling out those forms? And that's when we get social services involved and have them help us get those forms completed. So the completion of forms. Well, this patient is a full code, so they chose not to have any forms completed. Do not delete that whole entire segment. We're required to report what forms were completed. And if no forms were completed, that's the answer. Everything else gets deleted out. And then even though they didn't complete any forms, should something happen, they've said they want to be a full code, but should something happen and they have a decline or a change of condition, what would they want someone else to choose? And they wanted to be a full code. They're a full code now. And if they decline, they want to be a full code then. And then the amount of time that's spent. I have another example. This one is of a do not resuscitate. So again, we want the voluntary nature and then any names that of the people that participated. So that could be the patient, the patient's and the patient's spouse. If you're using just the patient's spouse, you would use the power of attorney template. Medical necessity. So let's say we've already established care on a patient and we're now documenting another advanced care planning session. What would be a cause to do medical necessity? So let's just say that the patient went to the hospital and they were receiving palliative or hospice care during hospitalization. Of course, we'd want to have another discussion. Do they really want to be a full code if they're on hospice? Or the patient has failure to thrive, protein calorie malnutrition, below ideal body weight, their BMI is 16, and they've developed a wound that looks like a Kennedy ulcer. This is a prime time to have another advanced care planning session if the patient is a full code. And then content, the goals of care. So this patient chose to be a do not resuscitate. So I just left non-aggressive management and comfort focus and deleted everything else that was not applicable to that. So that is the example of the do not resuscitate. Advanced care planning codes. It's a 99497 for advanced care planning. And Medicare says anything from 16 minutes to 30 minutes gives you that code 99497. If you spend more than 30 minutes with that initial visit, so more than 30 minutes, you can count both a 99498 and a 497. You're going to build both of those codes if you hit more than 46 minutes. And then always remember, you need an evaluation and management code before you put any additional codes in place. So you're going to bill your 99310, and then you're going to bill your advanced care planning. We're going to utilize the template in TrueRCM, and we're going to do a discussion anytime there's a decline or change of condition in the patient that would warrant changing advanced care planning. Again, my name is Brandy. I'm the nurse practitioner here. My phone number, my email is available for you. Please contact me at any time. If you have any questions, I'm available to you, and thank you for your time this morning.